Welcome to the first collaborative instructional module put together by the North Carolina Healthcare Association and the Advisory Board Company. My name is Connor O'Brien. I'm coming to you from the head office of the Advisory Board in Washington, D.C. This module, the first of three, is called U.S. Healthcare 101, Change, Threat, and a Call to Action. And let's dive right in. Much of what we see when we consider changes to how we deliver healthcare and how we are paid to deliver healthcare is summarized in this graphic here on this page. On the left, I think it's important to recognize that we, across the preceding decades, built a system that was responsive to that patient that you see on the factory floor. Kind of young, in relatively good health. Every once in a while might get injured or sick, and when that happens, we delivered acute care. Well, fast forward a few decades, and now that very same person is quite a different patient, isn't she? She is retired. She's obviously a bit older, might have one or two or more chronic conditions. And indeed, as opposed to being solely or primarily an acute patient, she is now in need of care on a more ongoing and chronic basis, also on a ratio basis, probably more medical care than surgical care there. And just the fact that the volumes of patients that we're seeing are increasingly like the one on the right suggests that there is a lot of change afoot. And we're going to talk about that change in three steps. Here's the first one. We're calling it How We're Paid. Push me, pull you. And I'll indicate the movie that that reference comes from in just a minute. Let's talk about how providers, whether they are physicians directly or integrated delivery networks more broadly, how we are paid. Three big groups on the left, government, and that includes Medicare and Medicaid. In the middle, large employers who are self-insured, and this also includes commercial insurers. And then on the right, consumers. These are patients who are beginning to shop around, like buyers in just about any other sector in the American economy. We're going to talk briefly about each one of these three. But let's start with the one on the left, government. And we'll begin by discussing the 800-pound gorilla in the payer space. That is CMS, the Center for Medicare and Medicaid Services in Washington. They run Medicare, which is still the largest and most efficient payer out there in our industry. Now, CMS, as the headline says, is letting us know loudly and very directly that they are moving away from fee-for-service reimbursement and toward value-based payment. Quick review, fee-for-service is payment per intervention, whereas value-based payment is reimbursement for outcome. Quite a different way to pay, quite a different way than that we have to organize our business to make sure that we are paid well. Now, here's the thing. Currently, roughly 97, 98% of reimbursement nationwide is still fee-for-service, and yet we're making the point that CMS is saying not for long, and here's why. Even in this calendar year, if you look at the graphic on the left, fully 50% of fee-for-service reimbursement programs coming out of CMS do have a component that involves financial risk. It may not be full risk, but there is some money, some reimbursement put at risk. That's 50% just this year. Over on the right, 90% of fee-for-service programs, Medicare payments, are tied to some sort of quality metric. So we will, at some point, see a change in the ratio of fee-for-value versus fee-for-service payments. But even now, Medicare is strongly suggesting to us, look, it's all about population health. We want you to build an end-to-end wholesale health network that can deliver population health. Pre-acute, subacute, acute, post-acute, those lines are dissolving as Medicare says, here's how much you get paid for that defined population. Keep them well. And if you can do that at low cost, great. If you cannot, it is you, healthcare providers, who are going to be on the hook financially for that, and not us. It's a very, very clear signal coming from CMS. And here's how that looks in practice. Here is a range of financial risk programs, risk reimbursement programs. On the left, pay for performance is something that you're probably familiar with because those programs were introduced starting years ago, and they, are pretty familiar to us. Over on the right-hand side is what we call here full risk, where again, the provider network is going to be on the hook for the financial performance of delivering care across a defined population. So on the left, sort of a slow start, toe in the water with regard to risk. On the right, complete and full risk on the part of providers. In the middle, bundled payments, shared savings programs, shared risk programs, indicate steps along the way, but you can see in the lists under each step, these are programs that have been proposed or are active right now. The writing on the wall is pretty clear coming from Washington, and that is population health, end-to-end care delivery, and financial risk. Okay, while we're talking about the government payers, let's pause for a moment and discuss Medicaid really quickly. Medicare, of course, the program for the elderly. If you're American and you're 65, you automatically qualify. Medicaid for indigent care and some child health care. And the story here is not so much about risk as it is more directly downward pressure on price. After the Affordable Care Act was passed, a number of states, 31 of them plus the District of Columbia, expanded their Medicaid programs, and in exchange for higher levels of federal reimbursement in their programs. But a number of states, they're the light gray colored ones on the map there, did not expand. A number of others in red, they expanded with a waiver that made them somewhat unique. Kind of a crazy quilt of programs, jurisdiction by jurisdiction on the left, but what they have in common is the trend on the right. The feds are reducing the percentage that they will contribute to Medicaid payments. It's already started, and it continues into the out years. And maintaining current course and speed, that is going to put tremendous pressure on state legislatures, where Medicaid is now usually the largest or the second largest budget line item in any state capital around the country. Well, that's going to remain the case, and we believe that those Medicaid line items are going to take up more and more of the state budget. Here's a quote on the bottom right from a state representative. In this case, in Louisiana, Medicaid could make up close to half of our state budget if this trend continues. Now, what does it have to do with us as providers? Well, when states begin to feel that pinch, they will begin, and in some cases they have begun, restricting access to care. And so patients that might have had a Medicaid plan might all of a sudden not. That might have implications for things like bad debt and so on. So the picture at the government level is one of increasing financial risk for providers and provider networks, whether we're talking about Medicare or Medicaid. Okay, moving on now. That takes us to the second group here. That's employers and large commercial insurers. Remember, this is the group that for decades has cross-subsidized the losses we tended to have made when we provided care to a Medicare or a Medicaid patient. So these folks are very, very important to us. They're one of the principal ways in which we've been able to keep our margins positive in an environment where most of our dollars are coming from the government. And here's what fascinates us about where they're coming from. They candidly, the large employers, the commercial insurers, do not believe that we can actually deliver the end-to-end wholesale healthcare value proposition that Medicare is demanding of us. All right, take a look at this quote on the left here. This is a benefits director for a large national employer. In other words, this is the person who buys the health plan, who pays for the health benefits of its employees. Quality doesn't happen at the system level. If I steer my employees to a single delivery system, the one thing I can be certain of is that the quality of care will be variable. While Medicare is saying population health, end-to-end care, full risk, the commercial insurers and the employers are saying, I don't buy it. I'll tell you what, I know you're pretty good at replacing knees and hips, but I'm going to send my heart patients to a different system, maybe a whole different time zone. And this is fascinating in the way that this is developed. How do benefits managers make those decisions? Well, increasingly, we're seeing that they do it with the help of what we're calling independent referral services here in the center. The independent referral services are data brokers, for lack of a more elegant name. They take a look at claims data, they take a look at some clinical data, and they provide it to benefits directors so that the benefits director can say, hey, you shouldn't go see this physician, you should go see that physician, or you shouldn't go to this facility or this network, you should go to that one, even though all of them may be listed in network in your insurance policy. So this is fascinating to us. The fact that armed with that information, the benefits directors are now getting an assist and finding themselves in the business of essentially further narrowing networks so that costs can be contained, because they just don't believe that we'll be as uniformly good at everything CMS wants us to be good at. Now, that's a lot of large employers. We also see what's going on in this graphic right here, a move toward not just the public exchanges, but private exchanges. These are offered by a lot of the, for example, large HR consultancies and so on. A private exchange, indeed we see some employers doing this with the ACA public exchanges. It allows the employer to get out of the defined benefit business. All right. Instead of trying to keep track of plan design and increases in cost and so on, these employers are essentially saying, hey, here's a stipend. Here's access to a network, an exchange where you can purchase policies. Godspeed, have at it. You can get the policy that's exactly right for you, and we don't, have to offer just one or two anymore. We see great growth and expansion in activity on these exchanges, and we expect to see it continue. So let's review where we've been so far. On the one hand, and at the top half of this graphic, we've got government paying us for wholesale value. Population health. On the other hand, we've got the cross-subsidizers saying, we don't believe you'll ever achieve it, and we're going to cherry pick, which is why at the top of this discussion, I use the word push me, pull you, because it reminds us of that fictional animal in Dr. Dolittle that couldn't seem to get going in one direction or the other because of its opposing heads. And this oftentimes is the impression that these forces moving in seemingly opposite directions have. But here's the thing. No healthcare system that we have encountered can blow off one or the other of these forces for very simple reasons. First of all, CMS in Medicare and to a lesser extent Medicaid represents a vast chunk of revenue for the average American healthcare system. And so their requirement that we move in the direction of population health and risk must not be ignored. At the same time, the commercial payers, the large employers in our markets, to the extent that there are centers of excellence, service lines that are well regarded and well ranked, perhaps externally. To the extent we have those, as we move in the direction of population health, there is a requirement, an imperative that we market that and we make sure that we are gaining the business that differentiates us thusly. So despite the push me, pull you picture from the last graphic, this is not an either or proposition. The successful providers and systems going forward will recognize that they have two large and important customers or customer categories, and both of what they are requiring matter to us, and that the way to outcompete is to find ways to deliver both of those. Which brings us to the final group, patients as shoppers, the rise of consumerism. I mentioned at the outset that, yeah, patients are starting to do things that we usually see consumers doing in other markets, other sectors. Principally, what they're doing is when they buy on the ACA exchanges or on private exchanges, they are trading nice low monthly premiums for very, very high deductibles. Low premiums, high deductibles, very popular in the exchanges and individual markets. And that is indicating three responses here. First of all, when you've got a very, very high deductible, you are more likely to forego care or at least postpone it. In some instances, this can make conditions worse, even emergent, and it drives up the cost of care. Take a look in the middle here. This graphic is very, very telling. Many American households, between a quarter to a third, do not have enough cash or other liquid assets to meet their deductibles. They've purchased the plan, they know what the deductible is, but they don't have enough in bank accounts or liquid assets to actually meet that deductible. And as a result, they are shopping very, very carefully. More than half of consumers search for price information, and that just never used to happen before, did it? I mean, when I go nationwide, I hear more and more stories of someone calling the physician's practice or calling the hospital and asking how much does it cost to get a knee replaced here. Well, I'll tell you what, it's no longer sufficient for us to say, well, here's a copy of the Charge Master. Good luck as you try to figure that out. And because that answer has been so complex before, there are all kinds of entrants into this space who are making available price information, transparent price information. Now, I said new entrants, but in fact, we see some incumbents doing this as well. Here's a story from right here at home, Blue Cross Blue Shield of North Carolina. Back in 2015, they essentially overnight released new pricing pricing information for every provider that they had paid over the preceding years. So in other words, you could sign in to the Blue Cross Blue Shield website, and you could look up a provider, you could look up a facility, and you could see, intervention by intervention, disease process by disease process, how much it costs to deliver care there. Instant transparency across the state of North Carolina from the biggest insurer in the space. Over on the right, this is an interesting one. Guru, Guroo, is an online tool put together by the Healthcare Cost Institute, including these big payers here around this orbit. Guru aggregates claims data from more than 40 million patients. And once again, it is an online tool that allows a readier answer to the question, how much will this cost? How much will this cost? This has been a question that other markets have recognized. Boy, we have to make it easy to answer this. And that we see this coming in healthcare now as well. All right. Our story so far. Government is pulling us in the direction of wholesale population health and full financial risk. Private payers, including employers, are pulling us in another direction, cherry picking those centers of excellence and service lines that they regard as best of breed. On top of that, you got this overlay of patients acting as price-sensitive consumers. When you add all this up, it means a lot of downward pressure on price, what we are going to get paid to deliver. And unless we are able to arrest the cost to deliver, we're going to be in a lot of financial trouble. Latest research from the advisory board suggests that our already narrow margins, operating margin in American provider networks, is about 2.5%. Very, very slim compared to other industries. Well, those narrow margins are under threat and could very likely become narrower still in the very, very near term. 5 categories of downward pressure on price at the top, from direct reimbursement pressure on the left, some of which we've already described, over to number 5, shifting demographics. In addition to downward pressure on price is upward pressure on cost, what we spend to actually provide care. Number 6 on the bottom there, no surprise, rising pharmaceutical costs, but there are other categories as well. Uncontrolled labor spending, increased reliance on IT, and the big sticker prices of things like unified EMR. And then over on the right, growth in purchased services. What does all this pressure mean? What does it look like? Well, it looks like what you see on this summary graphic right here. The 2 lines here represent revenue and cost growth. The light gray line is growth in revenue. And what it's saying here is that even recently, we are still seeing an increase in our revenues year on year. Nationwide, 6.6% revenue growth. Well, that's a good news story until you take a look at the growth of this cost curve. This dark gray curve here recently moved ahead of the revenue curve, which means now that our costs are growing faster than our revenues, and that is, simply put, unsustainable. The changes in American healthcare, both how we deliver and how we are paid, are putting us at a crossroads. And for most provider networks and provider groups, what got us to this point, what made us great, will likely be insufficient to sustain us across the next decades. There are communities counting on us to figure out a way to do this. And so I'd like to pose the question, what do we do next? Well, first, at the back end of this, we need to recognize the dynamics that we have just put on the table, the seemingly divergent directions in which payers are pulling us, and the imperatives that places upon us for care delivery. I'd also like you to consider the following questions before we move on into the next module. What specific external forces affect our internal strategy and operation? What is coming from outside that affects how we organize inside? And then the second one here, what can any individual do? What can I do to effect positive change in such a complex and threatening environment? Is there a role for the individual? I want to thank you for stepping through this with me across these last few minutes, and I will look forward to working with you again in our next module, which we call Advocacy and the Health Policy Ecosystem. Thank you very much.